plastic surgery. He then completed a fellowship appointment in aesthetic and reconstructive plastic surgery at Harvard Medical School at the world-renowned Beth Israel Deaconess Medical Center in Boston, Massachusetts. During his fellowship, Dr. Bishara gained state-of-the-art skills in fat transfer, body contouring after massive weight loss, reconstruction of Mohs defects of the face, neck, and scalp, and aesthetic and reconstructive breast procedures. He has had several publications and has traveled internationally to speak on topics such as risk analysis of combined procedures and body contouring after massive weight loss. Dr. Bishara is also active in patient education through seminars. After completion of his fellowship, Dr. Bishara completed additional training in hair restoration surgery with Dr. Mark DiStefano in Worcester, Massachusetts. He has performed hair restoration procedures with Dr. DiStefano in Massachusetts, Connecticut, Rhode Island, and Manhattan. Please join me in welcoming Dr. Mark Bishara. Thank you.
Thank you very much, Mr. Sinclair, for that very kind introduction, and thank you, Jess, for putting on a great symposium this afternoon. We had a great exchange and a nice media presentation. I can tell you throughout this tour in Asia that today I am the cleanest I've been because I've had 3 showers because of the humidity. So it's good to be here, and what a beautiful city that you all have, and I'm very jealous that you get to live here on a daily basis. Okay, so just a couple disclosures. Briefly, I am a paid speaker for both the Alma Laser Company as well as Restoration Robotics. This is just recapping a few things that Mr. Sinclair said just about my background and who I am. And this next scope of practice slide, I want to just spend a minute, maybe 30 seconds, just telling you a little bit about what I do on a daily basis. Currently, I'm in my 4th year of solo practice. When I finished my training, I hung a shingle. That's what we call sort of going into private practice by yourself, not going into a group practice. I hold privileges at a ambulatory surgery center, Baylor Surgery Care in Mansfield, Texas, which is a town between Dallas and Fort Worth. I'm also a attending surgeon that participate in acute care surgery about 6 times a month at the Methodist Hospital in our community. In addition to that, I hold a vice chair position, an anticipated chief of the department position in 2014, and I practice a large array of different things. The point of this slide is to tell you that despite the diversity of some of your training and some of the activities that you may be able to do, you can take a device like this robot and be very successful with it, in addition to some of the other things that you might be into. So, why did I decide to purchase the Artis initially as a non-hair focused practitioner? Before the Artis, I was probably performing about 15% of my time in hair transplantation. Well, the Artis itself was a device that allowed me to really get through a learning curve that was much faster than using a motorized or manual FUE device. It produces quality follicular unit grafts. It is precise and repeatedly precise and efficient. The speeds that the robot produces grafts at is very fast, and it was low stress for myself and my staff. This is sort of a situation in medicine and in hair transplantation that's creating a paradigm shift. And you'll see this cutting-edge technology is a very compelling story that sometimes doesn't need very many words to tell. The allure of having a robot that does hair transplant surgery is something that is quite phenomenal. In addition to this, it dramatically reduces the physician's fatigue compared to manual FUE. Now, just a little bit about the development of the ARTIS procedure. There's a lot of study design. Let's see if I can get this mouse here. There's a lot of several years. The robot company's been around for about 9 years, but the research and development goes back approximately 12 or 13 years ago, before it was clinically available. It was studied in 3 different clinical centers, and it was first used in humans in 2006. Of course, IRB approval and ethical oversight. Let me just play this quick video for you. These are some of the prototypes that were used, the concepts, the initial things that went into this very refined product that you see behind me. It didn't look that way. This is one of the initial robotic arms. And this concept had sort of originally been born to take grafts out and actually remove the grafts and place them on a table. And so there were several modifications that occurred throughout the last several years that have been refinements and ultimately have given us this very beautiful machine that you see behind us. This is sort of, part of a video that shows manual FUE for those of you that don't do hair restoration surgery currently. This is sort of it shows you how inefficient and slow that it can be sort of at the beginning of your learning curve. It's a very tedious and labor-intensive type of hair transplant surgery. Now, there are other devices that are motorized, and you can see that the quality of these grafts and follicular unit extraction that come out are have a high quality. And very rarely do they need to be trimmed or have any type of additional attention paid to them. Again, these are just more views of the prototype and the actual R&D side of things. So you can see that this is now becoming looks a little bit more, you can see this box. It's starting to look a little bit more like this box here with the CPU, PC-based CPU that's contained inside this box. And these are sort of a few extra slides of the first cases and the development of the skin tensioner. This was sort of designed after what's called a Lone Star retractor from colorectal surgery, for any of those people that remember what a Lone Star is. There was a lot of thought about the patient ergonomics going into the chair and what the optimum positioning would be for a robotic arm to swing around and approach the universal donor area. And so you can see this is getting closer to the device that we see that's in current use today, but it actually doesn't have the shell. This is the tool, so that you can kind of see the way that the actual device looks like and it works. And that's our finished product, okay? So you can see that the design concept here is so that you can harvest and then use the same chair to plant. You can just push a couple levers and lay the patient back in a nice reclining position and gain access to the hairline. Okay, this is a very busy slide, and most of the people are situated in the back of the room. So I'll just try to hit some high points on this. As far as the harvest process, for those of you that are doing hair transplant surgery, you know that if you're doing it through sort of a strip method, that this is still very dependent on microscopic dissection techniques, and usually under microscopes or under high-powered loops that are left up to technicians that are performing this skill. And then with manual FUE, you're still dependent on high transection rates, especially on providers that are at the beginning of their learning curve. whereas the artist gives you a predictable result from day one. When you look at the allocation of time, or how much time are you going to spend, really doing this, if you're using the strip method, to take the strip out, it's relatively quick to do that and sew up the donor site and hand that off. But it takes several hours for the technicians to dissect those grafts and prepare them for transplantation. The same is true for manual FUE, and we're seeing that the allocation of time for donor harvesting in the artist procedure is improving quite substantially as we understand even more about the FUE process. Right now, this grafts per hour at 500 grafts per hour is very conservative. This is probably on the lower end of things. In our practice, we're routinely averaging about 700 to 800 grafts per hour. There are cases of virgin scalp in a primary hair restoration procedure where we're easily hitting over 1,000 grafts per hour with everybody moving at the same, on the same page together in the room. So when you're dealing with manual FUE, unless you are Dr. Lorenzo from Spain, this is somewhat slower, substantially slower, and then the strip method is depending on the number of technicians. So it can be quite quick in strip method if you have 7 or 8 technicians that are slivering and then going on to procure the grafts, but most practices have 2 or 3 people that are working on this, and it can take them several hours. And of course, the more number of staff members that you have that are actually doing this, the more cost and the more cumbersome the procedure can become. Now, as far as the number of grafts in strip surgery, there is a slight advantage in that you can have a very large single session with a strip, and you have the potential for a large session in FUE if you extend this in the posterior auricular area and you come up in some of the other areas as they sort of move more anterior. Typically, manual FUE is limited to smaller sessions just by nature of the fact that it's labor intensive. When it comes to scars, the linear scar, particularly in younger individuals, has a tendency, and of course in Fitzpatrick type 4 skin, has a tendency to become hypertrophic or become almost lays down in too good of a fashion. And so you can sometimes have a very prominent scar from a strip-based procedure, as you know. And the scarring from the artist procedure is typically creating these soft tissue defects of approximately 1 millimeter that undergo wound contraction and will usually end up being about 0.3 millimeters, and they're very difficult to detect when you're more than about 6 or 8 inches away from the head. It's very difficult to see these scars. When you look at the healing time, it takes about 2 to 3 days to heal from a FUE approach versus about 12 days from a strip technique. And that's sort of an average until the sutures are removed. The recovery process for a FUE procedure is essentially painless. Okay, there can be a little bit of discomfort in the first evening. In our practice, we may use Valium or 10 milligrams of diazepam and some ibuprofen, but we don't use narcotics. And that's not true with strip-based surgery. Typically, strip-based surgeons are giving their patients narcotic pain medications for up to 3 or 4 days before transitioning them into ibuprofen. So, last but not least, the issue of being able to wear your hair short is important for some individuals. And if you have a linear scar that in some cases can go from one ear to the other, it would not be considered aesthetically pleasing if you cut your hair short and displayed that. And so the hair lengths after the procedure you can wear your hair relatively short, whereas in a strip-based surgery, you will need to keep your hair at least 2 centimeters long to conceal that scar. And the same is true really in equivalent in the manual FUE. Now this is just a breakdown of what the device is, sort of a anatomy of the device. The robot arm is a standard robot arm that's from the sort of borrowed from the automotive industry. There's nothing really unique or sophisticated about the arm itself. In fact, this is a very durable arm, and it's designed to work in automotive industries and other industries 24 hours a day, 7 days a week, for several years without having to be maintained. The procedure chair is sophisticated in that its design is ergonomic. The cart contains most of the computer equipment, including the central processing unit. But the most sophisticated part and the most expensive part of this device lies within what we call the tool. And that's this device that contains the video camera and the dissection tools. Okay. This is a picture of Dr. Jim Harris. He needs no introduction in the hair transplant world. This is a typical setup of how a case is done. A room layout that typically needs about 10 feet by about 12 feet to dissect the grafts in a comfortable fashion. Okay, here's another video that I'm going to play. This comes from Dr. Craig Ziering. Dr. Craig Ziering is in West Hollywood, not quite Beverly Hills, but West Hollywood he's actually in. And so this is a typical setup for a patient. They shave the head and they strap on this skin tensioner. Now, this tensioner device, we actually have an example of it here. We can actually pass it around if we'd like to. Okay. The skin tensioner is a 3 centimeter by a 3 centimeter device that has a series of image-guided fiducials that the camera system of the tool can pick up where the robotic tool is in three-dimensional space. It allows for acquisition of the density, the direction of the hair follicles, and the angles of the hair follicles, and allows the system to create a very precise dissection. When you see the turquoise circles, those are areas of previously harvested grafts. The green area, or the green circle, was the subsequent harvested graft, and the purple circle was the one in sequence that would follow the green one. Here you can see that someone is extracting at the same time as the tool is dissecting the grafts, is to sort of maintain some of the time, the concern for having these grafts outside of the body too long. Okay. This is also another animation. It shows you that the dissection tool is a hybrid between both sharp and dull punches. For those of you that know anything about FUE surgery, most machines are either a sharp punch or they're a dull punch. And this device is a hybrid, which has both. It has an inner coring needle that I'll demonstrate in a second. It is a 1.0 millimeter in diameter, followed by a dull rotating 1.2 millimeter coring device. Okay? The first needle will score the epidermis. The second needle actually dissects down through the epidermis and into the dermal layers and subcutaneous fat. There's a slight amount of suction at the conclusion of the dissection that slightly elevates the graft to a position that we call optimal graft elevation. And that is probably the single most important thing in robotic hair transplant dissecting, is to see that those grafts are being elevated to a slight degree that allows you to know that they're no longer tethered from some of the underlying soft tissues. Now, this is all automated. There are certain lines that the cameras are recognizing on the skin to determine the depth. And let's see, and it will automatically adjust at this point for the angle of the hair, for the depth, and for the direction of the hair follicles. So you can see as the dissection occurs, the initial needle scores it, followed by a dull coring device and a slight suction to elevate the graft. I think that's a loop. Is that a loop? Okay, this is the user interface. And I want to show you this video, but just before I want to point out a couple things that the interface shows you. At the top, before you start the dissection, this acquires and measures the density, and it tells you that there's 75 follicular units per square centimeter. So you get a digital readout and analysis. You have the number of grafts that were harvested so far in the case. You have the angle of the next hair follicle that it's about to dissect. And you have a Newton of force that tells you how much force is being used to create the dissection and how well that dissection is going. Down here are the areas where we control the puncture depth, the coring depth, the angle, and the RPM of the second coring device that goes down to dissect the grafts. Now, at this point in the development of the robot, all of this is automated. But approximately 1 year ago, when I was the 5th person in the world to have one of these robots, none of this was automated. So in a very short period of time, we've seen some software upgrades that have been absolutely phenomenal. And so you literally select the first follicle. Let me go back to that. You select the first follicle, and you push go. And this is what it does. It acquires all of the information that it needs to know about the tensioner, about what's in the tensioner, and you let it go. This picture is the puncture, is the sharp needle. It's the last punctured device, and this is the last graft that was dissected. So notice how these grafts that are created have hairs that are directly in the middle of the soft tissue punch. They're aligned exactly in the middle repeatedly, time in and time again. And so these circles can be modified, and they can be, the diameter of these circles can be increased or decreased. And so this is showing you a layer that the robot will not go back into, and it's denoting it as a no-fly zone because it's already been previously dissected. Now, you can modify these diameters to make this area more aggressive or less aggressive, more conservative, whatever your goals of the operation are. Okay. This, just to point out too, is an overview. It's sort of a bird's eye view to kind of demonstrate what's going on from a global tensioner. And this is just the zoomed in layer. Now, it would appear that some of these circles are overlapping, but in reality, they're really not. There's a 2-camera system, and each camera is coming in from different angles, and so sometimes the perception is that the graphs are overlapping, but they're not. Okay, I think that gives you the sort of the idea here. Okay, just a little bit about the clinical trials. So we define a transection in robotic hair transplant by a graft that becomes crushed, stripped, bent, or basically rendered untransplantable. There were 2 investigative centers, Dr. Wasserbauer and Dr. Harris in California and Colorado, and they studied this from January of 2011 until June 2011. And so they reported their initial data of 40 male subjects, and the final, final results that came out were 82. But this is sort of was the preliminary study. Showed an age range of 29 to 59. Hair types were red, blonde, brown, black, salt and pepper. We had straight and wavy hair. And some of these patients had previous small session FUE hair restoration operations. Now, it's important to realize the size of the procedure. And this size of the procedure that they were using were procedures that were greater than 728 and less than 1,876. And it's very important to notice that these were not studies that were done with 400 FUE grafts. When you get into the areas of having higher grafts, transection studies become more valid. And so they microscopically evaluated over 92,000 follicles, and they saw that there was an average transection rate of approximately 8%. The productivity of grafts, now this is not only dissection speed, but actually extraction as well, was 500 grafts per hour, and an average number of hairs of 2.4 per graft. There were no adverse effects or events that were reported during that, and no medical device malfunctions. Now this is what you look like, okay, one day after surgery. This is probably a solid 7 out of 10 result. Okay, sometimes you look a little bit better. Most of the time you look kind of like this. And this is sort of pre-procedural. This is one day after the procedure, and this is sort of 7 days after the procedure. So you get the absence of that linear scar and hair growth without having that aesthetically displeasing linear scar. Okay, this is a typical result that's being used in a lot of different presentations. This is about 900 grafts, bitemporal recessions, a solid Norwood 3A. That shows the procedure at post 9 months, and it's a very very natural appearing hairline. This does not look surgical by any means. Okay, here's a patient of mine. This is a Chinese individual from Texas who wears a cowboy hat and boots and has a very thick southern drawl. He had 1,100 grafts, and this is a picture of him in about 11 months. And arguably, someone might say, well, he could use some more hair in here, and he certainly could. I wouldn't operate on him before probably another 3 or 4 months, because I believe that you get even some delayed growth that goes beyond a year. The more I do this, the more I see that you continue to grow, even up to about 17 months. Here's another younger gentleman, 1,800 grafts, 13 months post-op. He's 23, 24 years old. He came into my office with a hat on. And so when we took his hat off, we said, leave your hair crushed like this so that we can take a look and see the scalp and take a better look, as opposed to combing your hair and disguising some of the hair. And you can see that these grafts look dramatically better. He's also a lead singer in a rock band in the United States. Now this is a gentleman, he's an orthopedic surgeon. He found us online. He underwent a 2000 graft case. I don't have a good picture with a similar angle for you of his pre-op photograph, because he sent his photographs to me online, and we did a Skype consultation online. But this is a picture of him after we've transplanted him at 2 months. So you can see that with the use also of PRP that we use on a case-by-case scenario, you can see the development of a little bit of growth in these areas, and a very nice, undetectable, wonderful result at 6 months after the procedure. So this is a fantastic result. Okay, here's another gentleman who's he's probably a little early in his postoperative period. This is at 7 months. He's had 1,200 grafts. He's probably around 31 years old now. And you can see that he can certainly, we'll take pictures of him in another several months and see how his hair has grown in. But this is a typical result for an FUE procedure at around the 6-month period.